Thanks so much for joining me. Today we're talking about diverticulosis. Diverticulosis is one of the commonest conditions I see as a gastroenterologist, but the interesting thing about it is many people don't even realize that they have diverticulosis. Some people have had a colonoscopy. One of the things that it's really important for you to understand is that when we do colonoscopy for colon cancer screening, which is the commonest indication for doing a colonoscopy. So I'm not talking about somebody who's having diarrhea or somebody who's had a change in their bowel habits or somebody who has blood in the stool. I'm talking about somebody you've turned 45, which is the age at which you're supposed to start screening earlier if you have a very strong family history, younger relative, but it's typically 45 or 10 years before the youngest first-degree family member was diagnosed with colon cancer. So if you have somebody in your family, let's say your mom or your dad or a sibling was diagnosed with colon cancer at 47, you would start your screening at 37. But for the average person, it's 45. So when you go for that colonoscopy at 45, gastroenterologists are looking primarily for polyps. And we know that polyps are the precursor lesions to colon cancer. So it goes normal tissue, adenoma, an adenomatous polyp, as opposed to a hyperplastic polyp, which is just a mound of normal tissue. So an adenoma and then carcinoma. And we call that the adenoma to carcinoma sequence. And that's what we're looking for when we do screening colonoscopy, looking for colon cancer. We don't want to find colon cancer. And by the way, you're in the right office hours. This is about diverticulosis. I'm just taking a little detour. So we don't want to find colon cancer. We want to find polyps. And polyps look like this. They look like a lollipop, like this. Here's a stalk and here's the head of the polyp. Hopefully not this big. You would be in big trouble if you had a polyp the size of my fist in your colon. But let's say more like this. So usually if a polyp is on a stalk, it's what we call pedunculated. This is a peduncle, and we are able to put our snare over it and close it and just basically slice it off. Sometimes we see sessile polyps, and if this is the inside of the colon, a sessile polyp is like this. So there's no stalk, it's just sitting right on the wall of the colon. So it's like a piece of chewing gum on the sidewalk, and those are harder to get off. Usually we inject the base to raise it up and then we put our snare over, but we have to be really careful because the wall of the colon in the second half of the colon, the right side of the colon, is only about 2 millimeters thick. And when we put the snare over, we're burning. So we have to be very careful with that. What does that have to do with diverticulosis? Well, I want you to think of diverticulosis as an inverted polyp, okay? So here's a lining of your gut lumen, and polyps are sticking up from the lining like that, okay? Here's your little polyp or your flat polyp. Diverticulosis is the opposite. It's a divot, okay? So polyps stick up into the lumen. Diverticulosis are like potholes. I was going to say, if you've ever been to Jamaica and driven on the roads there in my country where I'm from, but you don't have to go to Jamaica. You can drive right here in Washington, D.C., where the roads, I live right next to Rock Creek Park, and the roads, Broad Branch and Beach Drive going through the park are worse than our roads in Jamaica these days. So they did some sort of resurfacing thing that seems to have gone amok. And they're big potholes. So think of the road as a lining of your colon, and the pothole, which is a dent, a divot, right, in the road, like a hole, not going all the way through down to the center of the earth, but a little cave within on the road. That's the same thing that happens in your colon. And so that's why I like to think of them. And when I do colonoscopy, that's what they look like. They look like a crater. In somebody who has really extensive diverticulosis, their colon can look like Swiss cheese. You see those holes in Swiss cheese, those pockets? And obviously you want to direct the scope through the lumen, but if you have a lot of pockets coming off all around the side, sometimes that can look like the lumen, and you go off into one of those holes and you realize, it's basically just a blind end, it's a pouch. So in people who have really severe diverticulosis, a Swiss cheese colon, you have to do the colonoscopy very carefully and cautiously. The other thing that happens with diverticulosis is the wall of the colon gets really thick. So that makes it difficult to do colonoscopy. But why do? I started out by saying a lot of people have diverticulosis and they have a colonoscopy and the doctor never tells them, because as gastroenterologists, we're looking for polyps primarily, right? Sexy things that we can remove and prevent people from getting cancer. And so if you're going in for a screening colonoscopy and you basically say, yeah, I'm fine. I mean, maybe you don't perseverate on the fact that you have frequent incomplete bowel movements and bloating and gas and other things we're going to talk about. So you basically say, yeah, no, I don't have any blood in the stool. I haven't lost weight. I don't have a dramatic change in my bowel habits. They see the diverticulosis, but they don't see any polyps. And what do they tell you? Normal. So you have to take normal to mean that there are no polyps sometimes. And I tell you, it's shocking the number of patients who come to see me and tell me, I've had a normal colonoscopy 3 years ago. And I say, okay, but I'm just a little OCD and I would like to see the report myself. And I track down the report from whichever gastroenterologist did it. And sure enough, diverticulosis. So those of you who've had colonoscopies, I want you to go back and look at the report yourself. And those of you who are having, I want you to be sure to ask a gastroenterologist, ask her or him, did I have any diverticulosis? We call it tics affectionately in the GI world. Did I have any tics? So here's the thing. These are the symptoms of diverticulosis. You feel an urge to go, you sit down, you try to push it out, and just small little pellets come out or a thin stool. And you can feel that there's still more stool to come out, but it's not exiting. It almost feels like it's stuck. So you get up, you're like, okay, have a cup of coffee. You go have your coffee, kind of feel another urge to go. You sit back down, maybe a couple more pellets, maybe some gas, maybe another thin, narrow stool. Oftentimes, the first stool that comes out is hard, and then the rest of the stool is softer and less well-formed. And that can go on 2, 3, 4, 5, 6, 7 times a day, right? That feeling that you have to go, but when you sit down, it's just not coming out. And the second part of that is that when you wipe, you're often wiping and wiping and wiping and wiping, and the toilet paper is not getting clean. You're not getting a clean wipe. There's still a lot of stool schmear. I'm sorry if that's going to interfere with your bagels and lox and cream cheese, but there's a schmear on the toilet paper. And that schmear is a sign of what we call tenesmus, which is a medical term for incomplete evacuation. Why is there incomplete evacuation? Because all the stool is not coming out. Why isn't all the stool coming out? Because it's stuck in those pockets. So let's go over a little anatomy lesson to understand specifically what's going on. And we went over this last week, I think, with shy bowel. So I'm not going to get into the internal and the external sphincter and all of that, just the rectum there. So as food makes its way down through your digestive tract, and I always just like to go over this again, esophagus, stomach, the 3 parts of the small intestine. And I remember in medical school as dogs jump in. So that's duodenum, jejunum, ileum. So after the stomach is the duodenum, then the jejunum, then the ileum. So those 3 parts, duodenum, jejunum, ileum, all make up the small intestine. The small intestine, the end part, the ileum, attaches to the first part of the colon, which is the cecum. Okay. And right where the ileum joins the cecum is a little tail sticking out, and that's the appendix. But we don't have to worry about the appendix today. So the stool travels down through the ileum into the cecum, up the ascending colon, which is generally on the right side of the body, across the body in the transverse colon, which is right where it sounds like it is, in the transverse area. I'm showing you here in my breast, but obviously it's down in the abdomen. Transverse colon. Then it turns down on the left side of your body at what's called a splenic flexure. Where the ascending colon joins the transverse colon, that right angle on the right is called the hepatic flexure because it's right in the area of the liver, hepaticus, on the right. But on the left side, we call it the splenic flexure because it's by the spleen on the left side of the body. So it goes from the transverse colon down the descending colon to the sigmoid colon, that sexy S-shaped part of the colon, to the rectum, those last 6 inches that we spent a lot of time talking about last week. And then out, right, through the anus, and it's gone. So the part of the colon that is the muscular part, well, it's all a muscle, but the supramuscular part that has to contract to push it into the rectum is the sigmoid colon. And so that is where diverticulosis develops. Why does it develop there? Because again, that's the part that pushes it into remember the rectum is a storage organ. And in the West, and I mean us here in America, as well as other parts of the world like Western Europe and so on, we do not eat enough fiber. That's the sad truth of it. And we don't get anywhere near, most of us, to the recommended, in the US, it's somewhere, depending on which guidelines you read, 25 grams for women, 35 grams for men. But really that should be a minimum. And most Americans are getting around 10 to 15 grams. And unfortunately, much of those 10 to 15 grams are processed fiber. So it's cereal bars and things like that, which are not the same as whole grains and root vegetables and, brassicas, kale and cabbage and all of that stuff, and fruit, right? So you want to try and eat as much insoluble fiber as possible from and soluble fiber is good too, but you want to get it from whole food sources. So not something in a box or package. So with the skimpy amounts of fiber that we're eating, we are having skimpy stools. So we don't have enough fiber in the diet to bulk the stool into a nice big, I like to talk about the stools the size of my head that people are having in sub-Saharan Africa when they're eating a very unprocessed high fiber diet. And those stools move from ascending, transverse, descending, sigmoid, rectum. They fall effortlessly into the bowl, or usually people, in some of these areas are squatting. There's maybe not as good sanitation, but the stools fall out and, maybe they wipe and there's literally nothing. And in some parts of the world, in many parts of the world, there's not toilet paper available. So people are using a leaf or something improvised. But again, the thing I want you to know that in parts of the world where people are eating 60, 70, 80, 90 grams of unprocessed fiber, they are having fantastic bowel movements. And they are having no diverticulosis, no colon cancer, no polyps, no colitis, none of this stuff. So there's a direct correlation between the amount of fiber in your diet and what else is going on in your colon. But for those of us living in the more developed world, it is a direct, I say that in medicine, there are not a lot of things where you can draw a straight line, but you can draw a straight line between the amount of fiber in your diet and your bowel movements. And it's not just what you're doing now. You may be a fantastic whole foods plant-based eater now, but if growing up, you were basically a meat and potatoes with a little broccoli garnish to your meals, that's often when the foundation for diverticulosis and unfortunately colon cancer, polyps, etc., is laid down. So I see plenty of people who are great eaters now, but have one patient in particular, and I talk about her I think it's in Gut Bliss. I talk about her, Barbara, not her real name, but her name for the book, who is a judge, and I believe she was from the Midwest. So she was a fantastic eater now, but growing up, it was definitely a meat and potatoes diet, and she was suffering from really severe diverticulosis. So again, without that fiber to bulk the stool, you end up with a smaller, harder Western stool, and that sigmoid has to push really hard to expel that stool. And that's why the sigmoid colon develops those potholes. Now, you can see diverticulosis throughout the colon. We talk about right-sided ticks, but we talk about right-sided ticks for right-sided diverticulosis over in the ascending colon as an unusual phenomena, right? Because somewhere around 75 to 95% of patients with diverticulosis will have the sigmoid colon affected, and maybe further up too, like maybe the sigmoid plus the descending, maybe plus the transverse. But when it makes its way all the way over to the right colon, that's when we know this is pretty extensive. Now, remember I told you there's thickening that goes along with the bowel too, because as the sigmoid is trying to get that hard stool out, it develops a lot of hypertrophy, which means thickening. And so that is the reason for that narrowed stool. And sometimes when I scope people, I can see just tiny little pockets, but I see that the lumen is narrowed because there's a lot of thickening of the wall. Instead of the wall being, each when you're going around, like instead of it being this thick, now it's this thick, and that tends to squish the lumen. I wish I did a better job with my hand stuff. I should bring my GI model from my office, which is a model of the colon, intestines, etc. That's probably better than me trying to show you these things with my hand. But anyway, so you get the narrowing of the lumen and you have a narrow stool, and then you get the pockets and you have these pellets. And the reason why the consistency of the stool often varies, and this is something that people complain about a lot, is that the stool is sitting in these pockets, in these orifices, these potholes, and it's fermenting and fermenting and fermenting by gut bacteria. And so sometimes by the time it comes out, it's sort of ultra fermented and it's a different consistency. It's been sitting there longer, and sometimes it's looser. it can also be harder because if it's sitting there, sometimes water can be reabsorbed, so you end up with a hard pellet. Now, what is the reason why people have this urge to go, but the stool can't come out? So this is where we get into the mechanics of the sigmoid colon and the rectum. Remember from last time, and a quick refresher for those of you who weren't with us, that you can go back and watch it though. Go to gutless.com and go to the office hours page, a landing page. You'll see the archived office hours, and they're all recorded. This one will be up tomorrow. So there's a certain amount of threshold volume in the rectum you need before those stretch receptors trigger and all the, the internal sphincter relaxes, the external sphincter contracts, and the stool comes out, right? You guys remember? And so when these pockets fill up in the sigmoid colon, remember, they're not in the rectum. They're just above the rectum in the sigmoid. So they're nice and full, and they create a lot of pressure in the rectum. So that's why you feel that urge to go, right? And the sigmoid colon often will contract because it's full, but you don't have enough stool actually down in the rectum to trigger the stretch receptors because the stool is in the sigmoid just above the rectum. So it's like a false alarm. So you're like, oh, I have this contraction. I really need to go. You sit down, nothing. And that's why when I put people on psyllium husk, which I almost always do when they have diverticulosis, and we'll chat in a minute the difference between osis and itis. So for people who have symptomatic diverticulosis, and by symptomatic, I mean usually they're having bloating, they have gas, they're having incomplete bowel movements, they may be having bowel frequency, but they're incomplete. What the psyllium does is it sweeps those little pockets out, and it sort of consolidates all those little pellets in the thin stool into a nice big size of my head stool that can fall effortlessly into the bowl, right? That's the whole goal. So that's how psyllium husk works. And we like people to take the psyllium husk in the morning, a big heaping tablespoon with a lot of water, because remember, it's got to get through esophagus, stomach, duodenum, jejunum, ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid, rectum. That's a lot. It's like 30 feet of your digestive superhighway that the psyllium has to travel through. If you don't drink it with enough water, it will just gum up into a ball, and it will get stuck at all those sort of twists and turns in your gut, and it will just make you more bloated. So drink your psyllium husk in the morning. If I don't really have it anymore because I have my green smoothie instead, but if you need more fiber and you are putting it in the smoothie, make sure you make it liquid enough, add more liquid, because the psyllium will absorb a lot of the water and sort of can turn it into this gel-like substance that can be quite gross, quite frankly, if you don't have enough liquid in it. And again, plenty of liquid. It's just plumbing. Just wash it all down into the colon. Now, diverticulosis is the presence of these diverticular orifices, these potholes, okay? And that is upwards of 50% of the population in the US, over 45, 50. And now we're seeing, I mean, I scope people in their 30s now and see diverticulosis. It's not uncommon just because of lack of fiber. People are eating a highly processed diet. So I see so many of my patients eating these bars and different things and saying, oh, I'm getting 20 grams of protein, but 20 grams of fiber, but fiber from a protein bar is not the same. That's processed fiber, or inulin that's added into yogurt, or that's not the same as eating a sweet potato or lentils or an apple or, some celery, right? And it doesn't work the same in the gut. It's just not as digestively active, that processed fiber. So diverticulitis, anything with itis in medicine means inflammation. Dermatitis, inflammation of the skin. Arthritis, inflammation of the joints, of the cardiomyopathy, or even we would say carditis, inflammation of the heart tissue. Nephritis, inflammation of the kidneys. So diverticulitis is inflammation of the diverticular orifices. Now, I want you to keep in mind that I said inflammation, not infection. Now, what are the signs and symptoms? We talked about diverticulosis, right? The bloating, the gas, incomplete evacuation, the back and forth to the bathroom, the schmeary stool, etc. And sometimes with diverticulosis, it's not frequent small stools, it's just no stools. People are constipated and not going at all. But usually people are pushing out a little something insubstantial. With diverticulitis, there's usually pain. So there can be pain, which means, ouch, I feel pain. And there can be tenderness, which means when you poke me, when you palpate my abdomen, I'm really uncomfortable, right? So remember the distinction between pain, something you feel unprovoked, and tenderness, a sensation you have when the area is pressed or manipulated in some way. So people with diverticulitis will often have both. You can have symptomatic diverticulosis and have a little bit of pain if your colon's really full, but you're usually not super tender. When I examine you, I can feel a nice, but it feels like a sausage loop in your colon, but that doesn't usually cause a lot of tenderness. But when those diverticular orifices are inflamed and I poke you, there's usually an ouch. And there can often be a fever. If I were to draw labs with a severe case of diverticulitis, there would be an elevated white blood cell count. Now, we know that doctors overprescribe antibiotics in America, period, right? Because we take this sort of CYA approach. I'm going to cover my, what, just in case there's an infection, without really thinking about what the downside is of these antibiotics, which is why, and I'm like a stuck record with this, why we all have to be such good advocates and stewards with, when we go to see a doctor about saying, look, is this antibiotic absolutely necessary? So a lot of times if you go to see a doctor, and particularly maybe your primary care, your internist who's less familiar with diverticulosis, diverticulitis, they may say, oh, I don't know, let me put you on some antibiotics just in case. But that's not a great approach. Now, it's a great idea to use antibiotics if you have a rip-roaring case of diverticulitis and you have a fever, an elevated white blood cell count, and maybe you even have an abscess. That's a great idea. But if you basically just have a severe case of diverticulosis, where you're very symptomatic because the colon is full, or a mild case of diverticulitis, when you give a broad spectrum antibiotic, like they would typically prescribe, you wipe out a lot of the healthy bacteria. It means that your colon is now depleted of healthy bacteria. And what does that mean in the long run? It sets you up for repeated cycles of diverticulitis. So that's something I see frequently, is people who've been treated with a lot of antibiotics for diverticulitis tend to have a lot of flare-ups of diverticulitis. So antibiotics beget this recurrent cycle, because when the gut flora are unhealthy and imbalanced, when you've removed a lot of the healthy species, not only can it set you up for things like Clostridium difficile colitis, but it can also set you up for repeated episodes. So there's a really, there's sort of an art to knowing when you need to give antibiotics. Sometimes the doctor will recommend a CAT scan of the abdomen. Now, not surprising, I'm also not a big fan of over-scanning. Why? Because the literature shows that repeated exposure to radiation from a CAT scan is one of the causes of cancer. So, if it's also, CAT scans are also one of the main sources of revenue for emergency room departments, which is why it's always first test they do. There are a lot of things when you go to the emergency room that they can diagnose just fine with an X-ray. For example, a bowel obstruction, just a plain abdominal X-ray, which is minimal radiation, about the amount of radiation walking through the security thing at the airport. That abdominal X-ray will tell you quite definitively if you have a bowel obstruction, because we can see something called air fluid levels very easily. But oftentimes the emergency room will get a CAT scan because they can bill about 10 times more for a CAT scan than they can for an abdominal X-ray. So just, again, I just want you to, I'm not saying doctors are bad and hospitals just want to make money and everything is, is kind of set up to harm you or use you as an ATM. I just want to point out, I've been a doctor for 30 years, 31 this year, that there is a lot of commerce involved in medicine, and that's often what dictates the practices. So I just want you to be a good advocate and to, raise your hand and say, that's great that you have access to this CAT scan if I need it, but I just want to ask, is this really necessary? Is this really going to add something that you don't already know? Just a good question. Ask it in a nice, charming way. Okay. So the reason that doctors will get a CAT scan sometimes is if they examine you, make sure they're examining you, and they feel a lot of tenderness, they'll go, I wonder if you have an abscess. Let's make sure. Because if you have an abscess, which is just a closed pocket of pus on the CAT scan, that's a clear indication for antibiotics. And if the antibiotics don't resolve the abscess, you may even need surgery. Okay. But make sure it's not just, let's get a CAT scan without anybody laying hands on you and seeing what's really going on. The indications for surgery with diverticulitis are pretty rare, persistent abscess that's not resolving, or multiple cases of complicated diverticulitis, not just multiple episodes of diverticulitis. If you're having multiple episodes of diverticulitis, we need to figure out what's going on with your diet. Are you taking NSAIDs, non-steroidal anti-inflammatory drugs, Motrin, Advil, Anacin, Aleve, all of those ibuprofen-containing drugs, and aspirin can do it too. Those drugs can cause irritation in the diverticular orifices, and they can be a major source of diverticulitis. So when somebody tells me they have a history of multiple episodes, if they're having 3 or 4 episodes a year, I always want to ask them, are you taking NSAIDs? And then I want to find out what's going on with their diet. And here's a paradox that you really important to understand. For diverticulosis, which is a presence of diverticulosis, a presence of the orifices, you want to be on a high fiber diet, and things like psyllium husk and acacia fiber, all the fiber supplement, that's all great for helping empty the pockets. But if you are having an acute episode of diverticulitis and things are now inflamed, you want to ramp the fiber way down. In fact, you probably want to go on a liquid diet for 24 to 48 hours. That's the commonest thing I do for my patients who are not super sick and don't need to be in the hospital on IV antibiotics or anything like that. If they're having a flare-up of diverticulitis, sometimes even if they're having a flare-up of diverticulosis, in other words, there's no inflammation, but their diverticular orifices are just full to capacity, I will say, look, let's do 24 hours of a liquid diet. Let's just allow everything to empty. And I'll tell you, in addition to NSAIDs, the second, or maybe the commonest, maybe they're just sort of 1 and 2, commonest cause of a diverticulitis flare is constipation. So almost always, when somebody comes to see me and they have a history of diverticulosis, but now they have itis. Almost always they were constipated in the days preceding when we take our retrospectoscope and we march historically back with them through the history of what's been going on in the days before they came to see me. They'll almost always say, yeah, like say they see me on a Thursday, they're like, yeah, I hadn't really had a good bowel movement since Monday. Things were, just felt slowed down. Or they'll say, yes, I overdid it at my 6 a.m. CrossFit class. I took some ibuprofen for a few days. And then lo and behold, now I have an episode of diverticulitis, right? So I talk about this all the time, that things don't usually just fall out of the sky into our laps. Sometimes they do. And sometimes, that's very unfortunate. But so often there's like a little thread, right, of or dehydration is another one. So, I was traveling, I didn't want to be peeing all the time on the plane. And I was traveling, went to California, came back in 3 days, had a lot of meetings. I'm just making this up. And I just knew I was dehydrated, and that will do it. So, and again, anything that is going to slow down the movement of the products of digestion, which is just my nice way of saying the stool, can precipitate diverticulitis. Because if that stool sits in those pockets for too long, not only can fermentation, kind of ultra fermentation happen, but you can get a little inflammation there in the pocket. Okay, so avoid dehydration, avoid constipation, avoid NSAIDs. Those 3 are the most common triggers of diverticulitis. Keep it moving with a lot of water every day, especially if you have diverticulosis, because again, plumbing, you got to empty the pockets. Avoid constipation, use a little psyllium husk in the morning to sweep those things clean, use a little magnesium, either calm magnesium, oxy powder, magnesium citrate, magnesium oxide, recommended dose, little magnesium product in the evening. Make sure things are going. If you go, 2 or 3 days and you notice things are really slowed down, maybe that's a good time to do a liquid diet, bottle of citrate of magnesium, maybe even a couple doses of Miralax to empty out, because that should be a sign to you. If you start to feel bloated and gassy and you notice that your bowel movements have been less frequent, that is a sign that things are accumulating. And the next possible thing that could happen is diverticulitis. So this is the time, liquid diet, let's get empty, get it moving, okay? All right, I have been chatting nonstop. So why don't we take some questions? Why don't you go ahead and put them in the questions, or you can put them in the chat too, either one, whichever is more convenient. And I'll tell you that, we used to think of diverticulosis as something that we saw with older people. And that is still the case. But as I said, more and more younger people. And when people come in with this history of I'm bloated and I'm having incomplete bowel movements, it's literally the first thing I think of. And the kind of cool thing is that when people come in, especially if somebody's over 45 and they come in with this history, they're often worried about colon cancer. And I'm like, you know what? Very unlikely. Let's do the colonoscopy and see. And so when I tell them there's no colon cancer, you have diverticulosis, they're usually happy. I mean, then of course I start harassing them about the fiber, but when people have that change where things slow down and they feel like things are stuck and it's not coming out, they're often worried about a big tumor in the rectum or colon. And of course, if they're, in an age group where we'd be concerned, or really in anybody who comes in with an abrupt change in bowel habits, that's definitely something we want to rule out. And really the best way to rule that out is with a colonoscopy. But it's one of those times when, I can tell people are nervous, and it's really great to be able to give them good news, relatively good news. It's all relative. Okay, we got some questions. All right. How does a hiatal hernia contribute to diverticulitis? Or does it? It does not, but I'm glad you mentioned it, because I'm always happy for an opportunity to talk about the anatomy of the beloved digestive tract. So let's just take a quick detour. You guys don't mind, right? If we just take a little detour to talk about a hiatal hernia. We talked about the esophagus and the stomach, and they are joined at what is called the diaphragmatic hiatus. And if I were to show you, the diaphragmatic hiatus looks like this. So it's right sort of under the breastbone. Here's my sternum, and the end of the sternum right here where I can push in. And right here are the diaphragms, one on either side. And the diaphragms are important because everything above the diaphragm is in my chest, like my lungs and my heart. And everything below the diaphragm is in my abdomen, like my colon and liver, etc. Right? So the diaphragms mark the distinction between the chest and the abdomen, and also happen to be the area where the esophagus joins the stomach. And the diaphragms are like a thick fibrous tissue, and the lungs sit right on top of them, and they have a little opening in the middle between the left and right diaphragm where the esophagus comes down and joins the stomach. And right at that same diaphragmatic hiatus, that little hole there, is also the gastroesophageal junction, which is a sphincter that holds, and we haven't done reflux in a while, we should do reflux soon. So it's a sphincter that holds things tight, so that after you swallow and things go down the esophagus into the stomach, it closes tight so stuff doesn't come back up. So in normal anatomy, the diaphragmatic hiatus, that little opening between the diaphragms to let the esophagus come through, lines up with the gastroesophageal junction. But in some people, that gastroesophageal junction is a little bit higher. So the esophagus rides up in the diaphragmatic hiatus. So you have the diaphragmatic hiatus here, but the G junction is above it here. And so it means that the GE junction, the gastroesophageal junction, doesn't have the diaphragmatic hiatus reinforcing it. And when the GE junction is up, it means a little bit of the stomach is up above the diaphragm, right? Because normally esophagus here, diaphragm here, stomach below, right? Now I'm really getting crazy with the hands. So this hand, this forearm is your esophagus. This is your head. And this is the diaphragmatic hiatus right here. And my elbow right here is a GE junction, okay? And everything down below, invisible, is a stomach. But with a hiatal hernia, things are like this. So here's my GE junction up here, but here's my diaphragmatic hiatus. And what's between the hiatus and the elbow? It's invisible, but it's my stomach. So what that means, a hiatal hernia, is that your stomach is up in your chest. And I'm sure, my hand thing is just inadequate. Actually, I should get a whiteboard and I could just draw some stuff for you, though I draw very poorly, but I enjoy it. And I can feel like all Khan Academy. So just go look at a picture when I'm done here of Google an image of hiatal hernia, and it will show you, and you'll be like, oh, I know exactly what she's talking about. So the stomach is up in the chest. That predisposes you to reflux, but it doesn't really have much to do with diverticulitis. Now, I'm really glad you mentioned the upper GI tract, though, because when the colon is full, whether it's full because you just have regular constipation and you have a a lower colon full of stool, or whether because you have diverticulosis and you have a lot of pockets, potholes full of stool that aren't emptying. Regardless, you have a full colon. The colon will often send a signal to the stomach saying, don't bring anything more down here, we're full. We know about the gastrocolic reflex, which is usually triggered in the morning, the first thing you have to eat or drink, whether it's coffee, lemon water, whatever it is. As the substance hits your stomach sends a hormonal message to the colon saying, okay, it's time to empty because they are breaking fast and things are coming in and we need room, right? And so that will trigger your colon to contract. So that's a gastrocolic reflex, but there's a cologastric reflex where when your colon is full, it sends a message to the stomach, again, saying, don't bring anything in here. And what that can feel like is, for some people, it manifests as heartburn. For other people, it's nausea. Your stomach is basically just going to revolt and behave in a way that makes you not want to fill it up with, a porterhouse. And so that is a little bit of a connection, but no direct connection between hiatal hernia and diverticulitis. Okay, foods to avoid with diverticulosis. Thank you for that, Ona. Well, I talked a lot about foods you should have, right? So I want you to have a lot of water and a lot of hydrating things. Downstairs, I have cut up pineapple and watermelon. I'm going to go eat a huge bowl of both. And so those are very hydrating fruits, high water content. So those things are actually great to eat, especially, I really recommend eating seasonally. So in the summer months, if you can get your hands on watermelon and pineapple. Watermelon doesn't have a ton of fiber, but that's okay. But pineapple still has a lot of fiber. And pineapple has an enzyme in it called bromelain. And bromelain actually is a digestive enzyme that can help break down protein. Papaya, that's again, all these tropical fruits, warm weather fruits that have a high water content. Papaya has papain in it, which is the same papain that's in meat tenderizer. And that is, again, a naturally occurring enzyme that helps break down animal protein. So papaya, pineapple, these are wonderful fruits to eat, especially if you are an omnivore and you do have some animal protein on board from time to time, help break those down and also hydrate you and also provide fiber. So the best foods to eat are the high fiber foods, but I'm not answering your question, Una, because you asked what are the foods to avoid. So things that are binding, things that are low fiber, kind of constipating. So that would be things like a lot of cheese, a lot of bread, a lot of meat, things that really don't have fiber and tend to slow you down. Now, that being said, it doesn't mean you can't have any bread, meat, or cheese, because if that were the case, you could never go to France, right? You would starve. So you can certainly have those things, but in moderation and keeping in mind that those are things. Bananas are a fruit I love. I put them in smoothies. I love to eat them. I cut them up with berries. But bananas, when people are having diarrhea, we put them on the brat diet, the bananas, rice, applesauce, tea diet, that sort of bland, plug you up diet. So lots of white rice and bananas we think of as somewhat binding, but again, if the rest of the foods you're eating are highly fibrous, I think those are fine to eat. I dare say there are no foods I would say don't eat. Now, you bring up a really important point, Una, which is that in the last couple of decades, our feeling about food and diverticulosis and itis has changed. In the past, we would tell people, if you have diverticulosis, so not a flare-up, just a presence, don't eat things with seeds because the seeds can get stuck in those orifices. Well, if you've ever done colonoscopy, these orifices are big, right? Maybe a persimmon seed or an avocado seed, but I can't imagine a situation where you're actually swallowing an avocado seed. Who would swallow an avocado seed? Is that even possible? It'll probably choke you. So, or a cherry seed, nobody's swallowing those big seeds. But in terms of things like, grapes with pits, or even watermelon seeds, or berries, those are absolutely fine. Peanuts and other nuts, if they have sharp edges, if you chew them well and have enough water, they're fine. The one food I will say to be careful with is popcorn. Because with popcorn, they're often on-pop kernels, and those on-pop kernels are hard. And if you eat a lot of popcorn and you have a lot of those on-pop kernels sitting in a diverticular orifice, it might cause a little bit of inflammation. So save the popcorn for a really good movie. or, Wimbledon coming up or something, right? I wouldn't do popcorn every day if you have diverticulosis. So that's really the only thing I would be worried about. And again, like something with like a really sharp, nuts with a sharp edge if you're not chewing them well. Okay. All right, how do we fix long-term osis other than cilium? Yeah, so the key is you want to prevent it from progressing. And I'll tell you, a few years ago, I would have told you, like everybody else and every textbook, that diverticulosis cannot be reversed, but we can prevent it from progressing, right? So we can put you on a high fiber diet, put you on some cilium, and prevent more holes from forming. But I have now seen 4 people in the last 10 years who I scope myself, not like somebody else's report was diverticulosis and then I didn't see it. 4 of my patients who had mild to moderate diverticulosis, who changed their diet, and when I scoped them again years later, the diverticulosis was gone. And I would have said that was impossible if I didn't see it with my own eyes. So it's not the norm, but it can be done. But more often what we're looking to do is where you are with the diverticulosis when we diagnose you, halt it in its tracks, prevent it from progressing, and maybe make it a little better. So that my goal, I don't care if the pockets are there or not. The pockets themselves, they're not polyps, they don't cause cancer, it's fine. What I want is for you to not have symptoms, okay? That's my goal when you're my patient, is for you to be asymptomatic. Remember, we're talking about something that more than half the population over 45, 50 is going to develop. So if you have a few little diverticular orifices, but you're asymptomatic, that's okay. But I want you to be aware so that you ramp up your fiber and prevent it from progressing. That being said, I have to tell you, every time I go for my colonoscopy, I'm like, do I have diverticulosis? And so far, so good. Because I feel like, it's a marker that I'm not eating enough fiber, which it kind of is if you have it. So I'm happy to say that I haven't had any. Okay. Not that I'm bragging, but I kind of am. Okay. Carolyn, how much cilium per day is too much? I've been trying to take 2 tablespoons during the day for diverticulosis. Okay, Carolyn, you are a woman after my own heart. If you are doing 2 tablespoons, that's fantastic. But I'll say that if you are having trouble with that, slow it down. So here's what I do when I start people off. I will have them do a teaspoon of cilium in the morning before breakfast and a teaspoon before lunch with a lot of water. Then I'll have them increase it to a tablespoon and a tablespoon, and then I'll have them consolidate to 2 tablespoons in the morning. Okay, so I'll start with a teaspoon before breakfast, teaspoon before lunch, increase to tablespoon before breakfast, tablespoon before lunch, and then join that up to 2 tablespoons in the morning. But Carolyn, it may be that you only need 1 or 1.5, right? So it's not like the higher the better. The goal, the amount of cilium you need is the amount at which you become asymptomatic. And you may need a little bit of magnesium or some sort of osmotic cathartic at the other end of the day. So remember, these things all act very differently. The psyllium husk bulks, and the magnesium or the Miralax, but I don't want you using that every day, is the cathartic. That's the swoosh. That's how I describe it. One bulks, the other swooshes. So if all you're doing is bulking and bulking, you may run into trouble down the bottom because now your big, hulky, bulky stool is sitting at the bottom of your rectum, but there's no swoosh to get it out. Okay. And the swoosh may just be more water too. You don't necessarily need a cathartic, but I find that that combination works well. So with the 2 tablespoons, I'd say good for you for trying to get up to 2 if you feel like it's helping, maybe splitting them. So a morning and then like a, 11 a.m. or so dose. What if you have all of the osis symptoms, but itis is not on your colonoscopy report? Then remember diverticulitis is an acute event, and we would almost never see it on colonoscopy because when somebody's having a diverticulitis attack, we wouldn't do a colonoscopy on them because it's a high risk of perforation. And remember also that the vast majority of people with osis will never develop diverticulitis, okay? That's the exception, not the norm. Just like diverticulosis can bleed and bleed, massively to the point of hospitalization and blood transfusions. The vast majority of people with diverticulosis will never have that. These are rare complications. Bleeding from diverticulosis, that usually happens when somebody's taken one too many NSAIDs, nonsteroidals, and it's eroded the base of the diverticulosis and eroded down to the little feet or blood vessels, and now there's massive bleeding. Rare. Diverticulitis, uncommon. So I don't want you waiting around for this to happen. And again, it's not going to say it on the report, because when somebody's having diverticulitis, they have pain and tenderness, not the time to do a colonoscopy. We typically make people wait 6 weeks after an episode of diverticulitis before we would do a colonoscopy on them. So that's why, if I read your question right, what if you have all of the OSIS symptoms, but itis is not on a colonoscopy report? So I'm reading that to say that OSIS was on your colonoscopy report. Now, if you're having all of the symptoms of diverticulosis, but it's not on your report, then you probably don't have it, assuming you had the symptoms at the time of the colonoscopy and you haven't developed them subsequently. And good for you. And then maybe you're just having run-of-the-mill constipation, and I'm glad you're here anyway. Okay. Oh, good. I'm glad this is helpful, Jacqueline. 4 episodes in a year. I did get a colonoscopy, prescriptions to list certain foods and make you, oh, it's all trial and error. Okay. So no. It's really the lack of certain foods that will make it flare up. So this is the thing, Jacqueline. When you are having, I want you to be very, very clear on this. When you are having an episode of diverticulitis, low fiber, at the first sign of an episode, and you've had 4 in a year is a lot. The first sign of an episode, I want you to go on a clear liquid diet. I want you to go on broth, bone broth, chicken broth, veggie broth, whatever. Broth and water and coconut water. This is what I put people on. The brand I like Vita Coco unflavored coconut water. Don't get the pineapple one or whatever. It should just say plain coconut water, right? And I want you to literally get in, 3 to 4 liters between your broth, your water, and your coconut water. And I like the coconut water because it's high in potassium. It's gonna replete your electrolytes, okay? And that's all I want you to have until you start feeling better, which could be 24 hours, 48 hours, 36 hours, 72 hours. Obviously you don't want to go, much longer than about 4 days without having food, but a day or 2 of a clear liquid diet. If you feel that this itis episode was precipitated by constipation, this may be the time to do 3 or 4 capsules of Miralax to flush everything out. Let me just remind you and everyone else, this is not medical advice. I'm just educating you, telling you what I would typically do in a patient of mine. This is not for you to do, but you're absolutely free to discuss this with your doctor. So in this setting, I would typically put my patient on a liquid diet for 24 to 48 hours. I would usually tell them, do this for 24 hours, call us in the office or email us and let us know what's going on. And then if things aren't better, I'm going to say, do it for another 24 hours. If they are better, we'll talk about advancing the diet. Okay. If they also tell me, guess what? My bowel movements have been very scarce. They've been small, they've been incomplete, or haven't gone at all. I'm going to say, do anywhere from 2 to 8 capsules of Miralax, depending on how severe the constipation was, or do half a bottle of liquid citrate of magnesium or a full bottle of liquid citrate of magnesium. They call back the next day and they tell me, okay, basically I had like 4 pounds of stool come out and I feel much better and I'm not having the pain and so on. Then we'll start slowly advancing the diet, and I'll tell them do some soft stuff, like you could do some eggs and some mashed potatoes and things like that. But I won't put them back on the high fiber diet until they're really feeling back to baseline, because if there's some residual inflammation and you start ramping up the fiber, that can stir things up a little bit. Okay, so low fiber liquid for acute attack of diverticulitis, high fiber liquids, lots of hydration for just regular symptomatic diverticulosis. Okay. How much psyllium husk should I take per day, and should I take it once or twice per day? So Andrew, it depends on your symptoms. As I said, I would start with a tablespoon in the morning. And if you feel like that's not enough, ramp it up to 1.5, ramp it up to 2. If you feel like it's too much at one time, you can split it between breakfast and lunch. But I would say that of the patients I see, the average amount of psyllium is probably between 1 and 2 tablespoons, probably about 1.5. The psyllium pills don't work as well, and I think that's just because they don't dissolve well. So they tend to just stay gummy in the gut. So I don't like those as much. Can food trigger diverticulitis? It can, in the sense that food can trigger constipation. And I'll tell you, I see a lot of gluten intolerance in my patients with diverticular disease, in the sense that it's obviously not celiac disease, right? And it's not related, but if people are eating a lot of bread products, I find that's one of the common triggers for constipation, and then for constipation to trigger the diverticulitis. So just to be clear, I'm not suggesting that bread causes inflammation, but a lot of bready, baked wheat products can end up constipating you, and then that can trigger an episode of diverticulitis. So if I were to think of all the foods, it would be that, or people just eating, a heavy meat diet. The other situation I'll see it is in patients doing a low carb diet and eating, bacon, eggs for breakfast, chicken for lunch, steak for dinner with 2 broccoli florets, and that will do it, because again, just not enough fiber. So I really feel, Andrew, sorry, that wasn't Andrew who asked, anonymous. I really feel like it is the lack of fiber with these other things that can trigger diverticulitis. Okay, I was told that things with seeds cause a diverticulitis. This is true, like strawberries. As I said, it's very rare, and I think strawberries are off the list. But if you have something like the on-pop corn kernels that I talked about that can sit there, that can trigger an episode of diverticulitis. Do PPIs have any effect on diverticulosis or itis? I'm concerned about the suppression of good flora. It affects my overall health. Yeah, listen, you guys are like the advanced class here. You all know more than my GI colleagues. Like, how is this possible? This is incredible. So you've made such a fantastic connection there. So I just have to, of course, all of you are my star pupils, but here's the thing. Yes. So proton pump inhibitors, acid blockers, suppress acid, and in the process of suppressing acid, they disrupt the natural balance of the microbiome, right? Because we're supposed to have acid in our upper GI tract and low levels of bacteria, because the acid kills the bacteria, and we're supposed to have high levels of bacteria in our colons. But when you remove the acid, now you have a lot of bacterial overgrowth in the upper GI tract. And a very famous study that was published in one of our GI journals in 2014, looking at long-term PPI users, found that long-term PPI use was as deleterious to the microbiome as long-term antibiotic use, which is shocking. So they were finding mouth anaerobes in the colon instead of in the mouth, and it messed everything up. So in the sense that PPIs disrupt the microbiome, and particularly the natural gradient from low to high with bacteria, they can potentially interfere with that. If you're somebody with diverticulosis who's prone to itis, that is definitely something I would take into consideration. Okay, what is in tea that prevents diarrhea? I'm not sure, Cheryl, what particular tea you're talking about. I mean, there are types of teas like senna tea that I don't recommend, because senna is laxative, a stimulant laxative that the colon can become dependent on, but senna teas will cause diarrhea. So do me a favor, Cheryl, come back to me with that question and explain a little bit more what you're asking, because I think I'm just not understanding. Okay, how are hemorrhoids related to diverticulosis? Yes, yes, yes. Another fantastic question. You get it. Can skinny stools also be a symptom of swollen hemorrhoids? Yes. So certain things in the GI, you guys are like ready for your GI fellowship. So excited. Certain things in the GI tract travel together, and hemorrhoids and diverticulosis are best buddies. Why? Because they're caused by the same thing. And when you have not enough fiber, so when you have a small Western stool, not enough fiber, and you're straining, remember I told you you're pushing in the sigmoid colon, and that causes the pockets? Well, that pushing also causes the veins in the rectal area, the hemorrhoidal veins, to become engorged, and they go from being nice, flat, just regular veins to now being hemorrhoids, right? So it's the same etiology, is basically straining and a low fiber diet. Now, of course, other things can cause hemorrhoids too, right? So for example, pregnancy, just because there's kind of what we call venous stasis. So the pregnancy and the increase of abdominal girth, et cetera, can press on those veins and compress them a little bit, and you get backup, and that backup can affect the hemorrhoidal veins. So it's not always a low fiber diet, but that's the commonest cause. There are also anatomical things, like there's something called a rectocele and other things that can happen in that rectal area that can also lead to hemorrhoids. But fiber in the diet, not enough would be the number one cause. So that's why that's how hemorrhoids are related to diverticulosis. Great. And skinny stools too. Yes, with swollen hemorrhoids, there can be some compression of the rectum and the stools can come out skinny in that setting too. Tiny cucumber seeds. Yeah, those cucumber seeds are really soft. And I would say that if you ate cucumber seeds and ended up with diverticulitis, you might get written up. I mean, there would almost always be another precipitating factor, right? Like you were dehydrated and said something. So I don't think you need to dig out your cucumber seeds. I think that's absolutely fine. Just drink lots of water. And tomatoes, yes, those are tiny seeds. Any recommend for a gastroenterologist in the Metro Detroit area, having all the symptoms that was told her colonoscopy was normal? Yeah, Maria, I'm so sorry. I don't know anyone off the top of my head, but you know what I would do? I would look, and I apologize, I don't know my Michigan geography, but I know that University of Michigan, which is in Ann Arbor, which is maybe not that close, but they have a great gastroenterology department. And I would look at one of the teaching hospitals in the Detroit area. I just think it's always a good place to start, and call up the administrative assistant for the GI department. If they don't have somebody for the GI department, call the chairman's administrative assistant. See if you can get somebody on the phone or email them and say, who in your department is good with diverticulosis? But I'll tell you, diverticulosis is really bread and butter GI, right? I mean, gastroenterologists, some are better than others at sitting down and explaining, but you know, any gastroenterologist should be able to diagnose this. It is really GI 101 when you see these orifices. Okay, how did my 4 patients reverse their diverticulosis, Andrew? Diet, yeah. And I would have to go back and look at the charts for all of them, but 2 in particular I know were big meat eaters, keto people, and they got off that. I have to look at the other 2. How much magnesium in what form at end of day? So it depends, right? So if it's mild, I like to use calm magnesium, like 1 dose, a tablespoon. If it's more severe, I like oxy powder, which is an ozonated magnesium, and that's anywhere from 2 to 4 capsules at night. If you're kind of in between, I like just regular mag oxide, magnesium oxide tablets. They're generally at a dose of 400 to 800 milligrams. They're usually in 200 milligram capsules, so 2 to 4 of those. But, you know, it really depends on what form you're taking. And I wouldn't want to say 4 pills. And then I know oxy powder only comes in 1 strength, but look at what the recommended dose is for the particular brand you get. Okay. Does stool shaped like balls or pellets indicate diverticulosis or itis? Osis. But of course, there are other reasons you can have pellets too, but that would be a typical sign of diverticulosis. So if you have had a change in your bowel habits, like a change in the stool shape, I would always recommend that you see a gastroenterologist and get that checked out, get a colonoscopy if you haven't had one recently, and make sure there's nothing, you know, more sinister going on. So, because even though that would be typical, there are other things that can cause that, and we always want to exclude those. Yes? Okay. No, bentonite is not an acceptable substitute for psyllium. Bentonite is a binding agent. Bentonite will make you constipated. So an acceptable substitute for psyllium would be acacia fiber, A-C-A-C-I-A, like acacia, but it's pronounced acacia, but not bentonite. We use bentonite clay to bind for diarrhea. So bad idea if you have diverticulosis. Thanks for asking. How much water to take with 1 teaspoon versus 1 tablespoon? I say 8 ounces with a teaspoon and 12 ounces with a tablespoon. Brat diet is recommended for diarrhea. The T is for tea, correct? Oh, I see what you're saying. Yeah, the tea with the brat diet really is just a liquid, a hot liquid, because if we're putting people on this very restricted diet, we, you know, want them to be able to get in something. So when we put people on a brat diet, we're not super prescriptive about what kind of tea. And there are different kinds of teas. I'm a big tea drinker. You know, this peppermint tea and ginger tea is very calming. So sort of dealer's choice. But I don't think of tea as being therapeutic for diverticulosis. Okay. U of M and ROA, wonderful. And yeah, and University of Michigan, I mean, obviously there are good gastroenterologists and they're bad gastroenterologists and they come in all genders, but I will just give a shout out to my sisters at University of Michigan because they have one of the largest numbers of women on faculty and always have. When I came to Georgetown in 1997, shockingly, I was the first woman they'd ever had on the GI faculty. And I just found that kind of, so unusual. But Michigan already back in 1997, when I came here, Michigan already had a lot of women and great women like Grace Alta and others who've been there. So of course, it doesn't have to be a woman for your daughter. You might find a male gastroenterologist who's wonderful, but I just thought I would mention that. All right, so I did, I neglected the chat, but we're out of time. So let me quickly run through the chat. Oh, thank you, Lana. Thank you. That made my day. I really appreciate that. Compliments always welcome. Is tenderness always present with diverticulosis? No. Remember, osis is just the presence of the diverticula. You could be totally asymptomatic. So tenderness is usually a sign of itis, of the inflammation. So if you have no tenderness, but often incomplete evacuation, you probably just have diverticulosis. 90-year-old parent has it. So I called months after my colonoscopy nurse said, no diverticulosis. That's great. Is it hereditary? No, it's not genetic or hereditary. It's just that it's common. So if you have incomplete evacuation, I'm glad you don't have any diverticulosis. Good for you that you call the endoscopy nurse and just eat more fiber, drink more water. Okay. Just had an attack from Naomi, hospitalized with colitis, diverticulitis. Doctors keep using these diagnosis names interchangeably. Aren't they different diseases? They are and they're not, Naomi. So colitis, ulcerative colitis, is completely different from diverticulitis. It's an autoimmune disease, sister disease to Crohn's disease. But there is a condition called diverticular colitis, which is kind of a fancy way of saying the colon is inflamed from the diverticulosis, right? So diverticular colitis is kind of like diverticulitis. There's some subtle differences and nuances that we don't have to get into, but it's different from ulcerative colitis. And yes, they are different diseases. What is downside of taking Miralax every day for 7 or more years? Miralax is an osmotic cathartic, but it's a first cousin of antifreeze, essentially. And there've just been some studies in the literature, mostly in kids, but also in adults, of that substance going over the gut lining every day as being potentially damaging to the gut lining. So I wouldn't recommend taking it every day for 7 years. How much water with a 1 teaspoon? I think I answered that. What about Benefiber? Yes, Benefiber works well too. Citrusel works too. See which one you like. What brand? The regular Metamucil is fine, but make sure no artificial sweetener, no coloring. So that means the orange flavored one, it's more palatable, but it has FD&C yellow number 5. And I love just plain old Yerba Prima, Y-E-R-B-A, Yerba Prima, P-R-I-M-A. But I will tell you, when I had my husband on that, he was like, it's like chewing cardboard. And he's, he is somebody who eats salad morning, noon, and night, but it just, So I actually told him to switch to the orange flavored Metamucil, even though it had some food coloring in it, because I'll tell you, of all the flavored ones, I think it's the most palatable. It tastes like Tang, but do not get the artificial sweetener one. Regular sugar in it, which can be hard to find. It's not a ton of sugar, but the artificial sweeteners are terrible for your gut bacteria. Okay. We're going to have to come back to the nutritional liquid diet. I don't know what you're referring to there, Shirley, but I think you just mean a liquid diet where you're still getting some nutrients. 81 milligram aspirin, which you take for lupus anticoagulant disease. Marilyn, if you haven't had any issues with that baby aspirin dose, then you're probably fine. Just something to be aware of if you ever develop any bleeding from the diverticulosis, or if you're having frequent episodes of diverticulitis. But if you just have the diverticulosis and you're taking the 81 milligrams of aspirin and everything is fine, you're fine, all is well. No need to change that. Does stool shape like pellet balls indicate diverticulosis? It can be. The recording will be up tomorrow. You're so welcome. Ashkenazi Jews tend to get Crohn's and colitis. I don't believe there's a link between Ashkenazi Jewish heritage and diverticulosis, but I could be wrong, but I don't believe so. Oh, Carolyn, you're so welcome. So welcome. And everyone, I have kept you. I'm so sorry. It's my weak thing. It's my Achilles. I can just talk about stool all day long. It's so amazing. And it's always amazing to be with you. I wish I could see all your smiling faces. Next week, It's going to be a great one. And next week is a good one to come to, even if you don't have a vagina. It's not just for people with vaginas. We're talking about the risk of sexually transmitted diseases and how that relates to the vaginal microbiome, but it's important for partners too, right? So other vaginas and penises need to be aware of the risk of STDs. And as usual, I'm gonna, we're going to get in there and excavate. This is fascinating stuff. Do you know that some people, no matter how many times they're exposed to HIV, will never get HIV because of what's going on in their vagina? Isn't that incredible? That's the kind of vagina I want to have. All right. I'll see you all next week. Bye-bye.